So, Corey, I want to get your perspective. In the U.S., the approval for this is agnostic to PD-L1 status. That is not the case across the ocean in Europe, where there is some language. And if you could just walk us through that analysis that was done.
Is a hypothesis generating sub-analysis as part of this trial that analyzed PD-L1 status, and I realized just a bare majority actually had tissue that was sent for PD-L1. A significant minority did not. And this analysis, those who had absolutely no PD-L1 expression, at least in the context of this trial, did not have a survival advantage. If anything, the trend was in the wrong direction.
Yeah. But confidence intervals that were
confidence intervals were wide. They overlapped unity. And Europe has taken this to heart, whether it's a clinical decision or a financial decision. The approval is restricted to PD-L1 positive. I have to confess, I embrace this approach with enthusiasm, and anybody who's PD-L1 positive, I have a certain degree of ambivalence in PD-L1 negative. I will still offer it. If the patient and their family is intelligent enough or well-versed enough, I'll actually go over the nuances of the PD-L1
So
testing.
are you and others routinely checking PD-L1 in this setting?
Increasingly, in part because of this trial, and in part because it may inform subsequent therapeutic decisions if they develop disease progression.
Yeah, I have to agree with Corey. I think he summarized some of the reservations I had initially with the Pacific trial. I mean, ultimately, it's billed as a real-world trial, which to my ears as a scientist sounds like an uncontrolled trial for at least 50% of it. That, notwithstanding that, the overall survival advantage is compelling. But I agree, I mean, that subset analysis for me based on PD-L1 expression, it's not that this comes out of the blue. We have time and again seen that PD-L1 negative patients don't derive a lot of benefit from PD-1, PD-L1 checkpoint inhibitors. So this is in the context of that. And because it did cross, one on the bad side of one, there is a risk that there is some harm that might be present. So I think at a minimum, having that discussion with the patient in the context of a negative PD-L1 test is what I routinely do, and try to make it as understandable as possible, I think, to help navigate through that. It's also a year of treatment every 2 weeks. It's a commitment for a lot of people that can be tough.
And I do want to make sure we talk about the toxicity too, right? And though compared to many of our cytotoxic chemotherapies, certainly immune-based treatments in general are pretty well tolerated, but these are not, giving durvalumab is not without the potential for long-term toxicity. I have never prescribed as much thyroid replacement hormone until I started giving, immune therapy.
I completely agree,
right?
yes, I completely
and that's
agree.
not a toxicity that's going to resolve, right? And so there are some significant long-term issues, and especially if someone has the toxicity and then still has a recurrence of disease, which we still know is going to happen, maybe not in the majority, but certainly very close to that. And I mean, as we look at those survival data and the disease-free survival, it still probably is going to be most of the patients at some point recur, though the cure rates are increasing and are increased. And I think that's what we're also enthusiastic about with this trial. And I certainly offer durvalumab to my patients who have gone through concurrent chemoradiation, but we have to have those discussions and look, and if there are predictors where maybe someone's not going to benefit, we need to continue to look for that so that we're not giving people this long-term risk.
But you would agree, I think, that there were no surprises in terms of toxicity. And I want to get Kristen's thoughts on, I mean, one of the concerns during the conduct of this trial was, immunotherapy, pneumonitis, after radiation, pneumonitis. To your point, the radiation was not necessarily QA'd. And surprisingly, the difference was not alarming. In fact, no difference in grade 3 or 4.
Yeah, that's exactly right. We did not see high-grade pneumonitis with durvalumab. It is important, however, that you are aware that it could develop, and that if you are seeing signs of pneumonitis, you pick up the phone, call your radiation oncologist, try to figure out if the radiographic changes are in the radiation field, to understand if you think it's driven by radiation versus the durvalumab, because there certainly would be consequences. And then it's, of course, important to get treatment started for these toxicities if you see them developing.
You know, so it sounds like we have consensus that people would agree that in the appropriate patient that this is a new standard of care.
Absolutely, it's
Yeah.
practice changing. I mean, we went 25 years without a single positive trial in this realm.
Yes.
Concurrent chemoradiation was their standard of practice in that entire period.
So here's the million-dollar question. What do you do when a patient relapses after a year? Let's say they relapse within 6 months of completion of durvalumab, or what do you do if they relapse 2 years later?
Because in my practice, I mean, this isn't theoretical. These are my patients who have come in. So, this is where I'm going to talk about EGFR again, because in my practice, I mean, this isn't theoretical. These are my patients who have come in, and many of them, because of the nature of our practice, have had EGFR known mutations, have been treated with the Pacific regimen. They got their concurrent chemoradiation. They've been on durvalumab. They have relapsed, some of them, not all of them, of course, but as we would expect, some have. And then in the setting where someone's already had exposure to immune therapy, there's separate risks that can come into play when you're then challenging them with EGFR therapy. Right. And so I've actually had some issues where I've been concerned about giving osimertinib directly after giving durvalumab or any other immune therapy. And so we've actually gone back to using a bit more of erlotinib in that setting. So that's just something for people to be aware of, is that there is some potential increased risk of pneumonitis with osimertinib in combination or directly after immune therapy compared to some of the other TKIs. Now, that's more in the kind of, they're relapsing during treatment as opposed to, well, if it's been 6 months, I wouldn't be as worried about that. And if they aren't going to be getting
Corey, your thoughts?
Or
EGFR therapy
more,
or other targeted treatment,
immune therapy
again, looking at the timing, but I'm usually going to give combination chemotherapy plus immune therapy
alone,
for
although
those
I think
patients
that's
if they
still
don't
a
have a
testable
driver
question
mutation.
as well. And again, it's histology appropriate chemo, even if they had previously been exposed to chemo, which they are. By definition, these folks have gotten concurrent chemoradiation. I think the point you're making about immediately following immunotherapy with a TKI in the EGFR positive population, that's something that's certainly coming out in stage 4, and it's a growing concern in this population. Only 40 or so patients even had EGFR mutation on the trial, and granted their PFS, the hazard ratio was a bit higher. It was still on the right side of 1. And the survival, we haven't even seen the forest plots for that group. So I have offered this regimen to at least to EGFR mutant patients.